Hi, Dr. Edward. Hi, Dr. Marilyn. Hi, Dr. Tommy. This is great. Well, today we're going to be discussing, is it your patient, Dr. Marilyn?
Yes.
Yeah. Discussing, would you like me to share my screen, or would you like to share your screen in relation to the test results?
No, I think you can take it on from here, but probably you just give me maybe 1 or 2 minutes to go through her history. And
no
then,
problem.
Yeah.
Now, can you see my screen?
Yeah.
Yes, excellent.
Yeah.
So tell us a little bit about your patient.
Yeah, I'm just trying to get her history up here. Okay, so she's a 68-year-old lady. I've been following her up for since 2018 now, so this will be the 5th year. She was initially diagnosed with insomnia, and that came together with a diagnosis of IBS-D, so the IBS but diarrhea type. So for the insomnia, I think we've had previous Zoom meetings before. She was initially on 3 medications from the psychiatrist: Xanax, Lexapro, and olanzapine. But I think with time, we've been able to wean her off all of that. And currently she's only on Remron, which is a mirtazapine.
Mirtazapine, yes.
Yes, and that too, just a 3/4 of a tablet, so 22.5 milligrams. She feels like she doesn't need that to sleep now. She's able to sleep train and do a good sleep hygiene. But the thing is, every time she lets go of this Remron or the dose goes a bit lower, then the IBS-D sort of flares up. So we're wondering whether it's actually more to calm down the tummy or, for the sleep support. But the IBS-D was diagnosed same time in 2018. She's had very strict adherence to the low-FODMAP diet. She's had annual OGDS done, and all the time the gastroenterologist tells her there's nothing wrong with her stomach and her colon. The findings are always normal, not even inflammation or polyps or ulcers. So recently she got attached to a university hospital in Kuala Lumpur, and they're a little bit proactive about managing IBS. They sent her for a SIBO breath test, which I think finally is just a hydrogen breath test, and was told that the results were negative last year in 2021.
So it was just hydrogen, not hydrogen and methane?
Yes, no, just a single bag, just hydrogen, and she was told that it was negative. But the main problem that I'm having with her is that she's just having loose stools periodically. So it fluctuates from brown to green. Like if you see in this sample, it says brown stools, but I would say 50% of the time she's actually having green loose stools. So
that's indicative. Green stools are really indicative of some form of infection.
Yeah. Right. Yeah. So it would be the Bristol 4 or 5, on the stool chart.
Sure.
And the other thing is that ever since on the onset of this diagnosis 4 or 5 years ago, her weight has been chronically low at 46, 47 kilos. Her ideal weight and body composition should be about 49 to 50 kilos, which was what was normal for her. But we're just stuck at that ceiling of 47, 48 kilograms.
Okay.
And then now recently, just a last visit to the gastroenterologist in the university hospital, she was actually offered to go on a clinical trial with rifaximin. So in view of these results, it's just coincidental that we did this microbiome test, and we have now more in-depth look at her microbiome. So I'm just wondering, is she now a good candidate? Is she even SIBO, or is she IBS-D, or what is she? So back to you.
So what we'll do is, it's great for you to share her clinical history. It's clear that the mirtazapine has actually made a difference for her in terms of her sleep, but it also impacts on her gastrointestinal tract. So there is a gut-brain axis. So we'll have that conversation after we discuss the complete microbiome map. So you've sent a sample of stool to the lab, and the lab has come back with some results. In the first part, or first panel, we see her stool is unformed, and that confirms her loose stool that you had mentioned. The next panel is possibly most important in that her calprotectin identifies and differentiates between IBS and IBD. So IBD is ulcerative colitis and Crohn's. What has she been diagnosed with?
IBS. So irritable bowel syndrome type D, the diarrhea type. Yeah.
Okay, diarrhea type. So she has this clear. Because calprotectin is so elevated, I would encourage you to refer her on for an endoscopy to rule out any Crohn's or ulcerative colitis. If that is ruled out, then we know that this calprotectin is directly associated with inflammation.
Yeah, right? she's had her colonoscopes done the same time with her gastroscopes, so it is clear. Yeah, so they have ruled out. Yeah. So
the calprotectin, as you said, she's IBS-D, so there's a tendency towards IBS and diarrheal. However, that calprotectin is extremely, it's close to more than double the upper limit, and that clearly indicates that she's very acidic. Now, very acidic and very inflamed. So you need to look at strategies to drive down the acidity. The pancreatic elastase is 150. So ideally, you want the pancreatic elastase in the optimal range above 500, and hers is below 200. So here you need to actually probably look at something like supporting her pancreatic function with something like Creon Fort, for example, to actually ensure that you're supporting her pancreatic function. But simultaneously, you might need to have a look at her blood amylase and lipase levels to ensure that all her digestive capacity is optimized. So I would encourage you to look at digestive enzymes together with something like Creon Fort. The next thing we see, her secretory IgA is super low. This is a marker of the gastrointestinal immune integrity of the gastrointestinal mucosa in the colon. And that's where the immunity lives. So if she's got no immunity, in other words, there's no mucus inside that colon, her stool is actually being purified and fermented and really acidic. It's really eating into her colon, right? And this is the reason why she's not absorbing any nutrients, and she's only 46 kilos. So the focus of attention really has to be on driving down the inflammation as well as building up the secretory IgA. And you do that with prebiotics together with partially hydrolyzed guar gum. The next thing we see is that her zonulin, as a result of no mucous membrane on the inside of the colon, she's now developing a leaky gut. In other words, the cells are separating and those toxins are moving into the bloodstream. So her zonulin is elevated. When zonulin is elevated, she's got leaky gut. All right. So now you know that she's got inflammation, she's got poor digestive function, she has leaky gut, and she's got poor immune integrity of the gastrointestinal mucosa. And this is the reason why she is dependent on neurological support, because GABA and serotonin is actually made in the gut. So if it's not there's no resources available for her to make that in the gut, there's no way she's going to be mentally stable. Next thing is a beta-glucuronidase is on the low side of normal. It's within normal, that's fine. Steatocrit is fine, and antigliadin IgA is fine. So that's good. The next pathway we look at is her microbiology. Now, we'll come to this in a minute because this is very important. Her bacteroidetes is low and her firmicutes is high, and I'll explain that in a minute. What we see is, we're seeing that she has no parasites and no worms, but she has opportunistic bacteria, and she has a number of them. Now, opportunistic bacteria are, in actual fact, the good bugs. They generally live there in harmony in the gut. When they are out of balance, in other words, when they're out of this range, then they become pathogenic. Now, Bacillus is just slightly above. It's not a big deal. Enterococcus is 7 times the upper limit. Pseudomonas is 36 times the upper limit. Pseudomonas aeruginosa is 141 when the upper limit is 5. She's got a lot of bacterial dysbiosis in the gut. All of those are associated with bacterial infection. Now, what is of greater concern is that she has 2 microbes, Klebsiella and Citrobacter, which is close to 10 times the upper limit, These are the two microbes that are directly associated with autoimmune triggers. And these can be, your autoimmune diseases such as AS or such as chronic fatigue, etc. So the literature clearly shows that there's an association between these microbes and autoimmune disease. The next panel we see is that a fungus, she's got no fungal infections, she's got no bacterial pathogens, she's got no Helicobacter, she's got no viral infections. But look at her normal probiotics, her symbiotics. Yes. They are extremely low, some of them are high. Now, she's got Enterococcus that is elevated. She's got Enterobacter that is elevated, and these are the good bugs. She's got no Akkermansia muciniphila. Look at the word muciniphila. This bug produces the mucin layer. That's part of the mucus layer within the colon. So therefore, you need to support that immune integrity of that gastrointestinal mucosa stat. Absolutely immediately. So the overall probiotic load is on the low side. Now, remember I said to you that her Bacteroides and Firmicutes were out of balance. Right. Now, the phyla, if you look at good bugs, the phyla are the families that they Bacteroides, Firmicutes, their other phyla, Actinobacteria, Proteobacteria, etc. The two main phyla are Firmicutes, of which Lactobacilli is the main probiotic there, and Bacteroides, of which Bifidobacterium is the main probiotic. Of course, there's a whole lot of others underneath that. So when we look at something like this, we can see that Firmicutes is considered to be what we call the fat bugs. There are some people that are obese but cannot lose weight. And that's because, despite the fact that they're starving themselves, and so these are people that will have an imbalance of the Firmicutes versus the Bacteroides. So when we identify this and we look down into her probiotic load or her symbionts, we can see that she has a deficiency of the Bifidobacterium, she has a deficiency of the Lactobacilli, and she's got excesses of Enterococci, and these are symbionts, not pathobionts, and she's got absolutely no Akkermansia muciniphila. So when we put this together, we can actually see that you might want to encourage her to have a look at your neurotransmitters, which is code 4035. And the reason you want to do that is she has insomnia, she has neurological imbalances, and she has no gut reserve. And therefore, you expect to have absolutely no GABA or absolutely very low serotonin in her system. And this is why she's dependent on something like mirtazapine. All right. Okay. So when we see her next phase is short chain fatty acids, they're all within the normal range and they represent dysbiosis. It's clear we've got dysbiosis, right? So now when we actually look at the overall picture for her, what we do definitely need to do is we need to institute a 4R protocol. Now, a 4R protocol, because she is so significantly bacterially loaded, both with Klebsiella and Citrobacter, which are really potent autoimmune triggers, we do need an antibiotic followed by herbal antibacterials. Okay, so now it's an issue of finding the most narrow therapeutic index. Now, you mentioned rifaximin. What justification do you have in terms of rifaximin, considering she is hydrogen negative for SIBO?
Right. It was just planned by the university hospital and stating that it's not to target any particular strain of bacteria, but just to repair the leaky gut and the gut junctions. That was the indication.
Okay.
Yeah.
And rifaximin is probably one of the most potent and is really targeted for SIBO. And because you only have half the picture for SIBO, I can't confirm whether this patient has SIBO or not. One of the ways that you can actually get, one of the major areas that you can actually identify if this patient actually has SIBO is through a microbe called Methanobacteriaceae. Now, did we do that one on this test? Opportunistic Methanobacteriaceae is within normal range. If this was elevated, then I would say that she's methane positive.
Okay.
All right. So therefore, would I suspect SIBO for her? Perhaps, perhaps not. I can't confirm it. Based on the fact that Methanobacteriaceae is low, I would suspect that she she may or may not have SIBO. Okay. Unlikely that she has SIBO. So the bottom line here is we need to, our focus of attention is remove those microbes. So you use an antibiotic to address Klebsiella, Citrobacter, and the antibiotics are listed in the body of the report. So definitely look into those antibiotics. And I would always follow it up with a herbal antibacterial. So that's the first step. The second step is you will need to restore the digestive capacity. And so you need to raise that pancreatic elastase, examine amylase and lipase, ensure that you're putting the right digestive enzymes, including pancreatic enzymes, into the system. And the pancreatic enzymes might mean long-term. Now, if she has any beta cell dysfunction in the pancreas, then you might want to look at HbA1c, fasting glucose, fasting insulin, and rule out any pancreatic dysfunction as well.
Yeah. We've done that. She's quite clear on that. I mean, the fasting insulin is quite low.
Excellent. So therefore, you will need to give her pancreatic enzymes. Now, because of the fact that she has an exceptionally high calprotectin, we are suspecting severe acidic environment in a system. Okay, she might be very super stressed. She's terribly inflamed. Therefore, I would consider alkalizing strategies. Examine where her acidity is through a urine pH test or a stool pH, etc., and examine exactly where her inflammatory load is coming from. Is it through a stress component or is it acidity? And then you can look at alkalizing strategies. Then the third step, once you've actually removed all those microbial infestations, you've replaced with the digestive support, then you continue replacing on the digestive support, and then you start the next process. And that is the repair and re-inoculation. This is a long-term part. This is the reason why we want to do this, is we want to restore that immune integrity of the gastrointestinal mucosa. We want to repair those leaky gut situations in the colon. So how do we do that? We use prebiotics that have anti-inflammatories in them. So you could use something like your slippery elm, marshmallow, arabinogalactone, lactoferrons, FOS, the oligosaccharides, and add to that your partially hydrolyzed guar gum. Then you need, because the probiotics are so low, we need to then restore that diversity of the microbiota. And we do that through probiotics. Now, ideally, what I do personally is I use about 3 different brands of probiotics. One that is specific for inflammation, which contains a lot of Lactobacillus rhamnosus, Saccharomyces boulardii, Bifidobacterium animalis, those sorts of probiotics. Then I'd use a different brand, not the same brand, a different brand, because they're different strains, of a multi-strain probiotic. And I would probably use two to three different brands, and I would pulse them 3 days on one, 3 days on another, 3 days on another, so that I'm improving the diversity. You might need to incorporate some of the fermented foods in this patient's diet as well. So you say you've done a FODMAP diet. There's nothing wrong with a FODMAP diet. Is she responding positively to that diet?
Yeah, she's quite sensitive. She's also done a food sensitivity test, food tolerance test. Yeah. So we found that she's extremely allergic to all dairy products, eggs, even nuts. So she's cleared that and adhered to that, I think, for about 1 or 2 years now. But the moment she sort of does a test, like just a spoonful of dairy, then the whole inflammation comes back. So I feel like we haven't treated her gut.
You haven't treated the gut correctly. No. And you have to do it in the step-by-step approach, because this is the most important part. Your 4-hour protocol or 5-hour protocol is literally removing the microbial infestation, then replacing the pancreatic enzymes as well as digestive support, as well as alkalinizing the system. In conjunction with replacing, you would start to re-inoculate. And you re-inoculate with your prebiotics together with anti-inflammatories. Often you'll find a lot of these anti-inflammatories are found in commercial prebiotics that are found together. Don't forget to add the partially hydrolyzed guar gum, because that actually makes a huge difference in her diarrhea, in her prebiotic load. And then the probiotics, I would encourage you to look at 2 or 3 different brands and strains of various anti-inflammatory probiotics together with a diverse multi-strain probiotic. You can combine the re-inoculation and repair very effectively if you combine some of the formulations together. And simultaneously, I would encourage you to look into her neurotransmitters. And the more you restore that immune integrity of the mucosa, the better her mood will be, because then you're providing the substrates for GABA and serotonin production. All right. Make sure
2 years ago, we did do the neurotransmitter testing and did show almost nil to none levels of serotonin. And the GABA was low and normal.
So if you've done her neurotransmitter testing, make sure that you're incorporating all those amino acids that are the substrates for the production of your tryptophan, your dopamine, your GABA, etc. So they are, and incorporate those proteins in a formulation that's specially designed for her. So you could have an amino acid formulation. If she's got low GABA, put the glutamine, the L-theanine, the mucuna, the GABA, all of those sorts of things into the system. If she's got low serotonin, put the 5-HTP, the serotonin, the B6, the tetrahydrobiopterin, the iron. If she's got low dopamine, use this tyrosine and phenylalanine together with the cofactors like copper and so forth. So it's very important to actually ensure for somebody who is malnourished, in her case, she is only 46 kilos, indicates clearly that there is a major neglect of her health from her nutritional perspective. So she's malnourished. So you need to, you're doing the right thing in terms of FOD mapping. Are you restoring the right amino acids into a system to enhance the production of neurotransmitters, to support the branched chain amino acids such as leucine, isoleucine, valine, to actually support the muscle function in her body? These are things that you might need to think about.
Okay. So back to the antibacterials, the herbal antibacterials. How long are we talking for?
Generally, you would use those antibacterials for 7 to 10 days, and then follow it up with and obviously you need to be mindful of the patient's antibiotic resistance, antibiotic sensitivity, dosing, frequency, all of those parameters that you need to be mindful of, based on her physique and her capacity to withstand them. But it's clear that she does need antibiotic therapy. Follow it up with, so you use that short term and you're continuing so that you're not getting a reinfestation later down, continuing with antibacterial herbals.
Yeah, so the initial course from the generic ciprofloxacin or amoxicillin will be about 7 to 10 days. The herbals continue for how long for usually?
You could continue that for a good month.
Okay, and they overlap from the beginning, or they?
You'd usually do the antibiotics first, and then you follow it up with the herbal interventions. Yes.
Okay. And you mentioned this Cryon 4 at the beginning for the
Creon
pancreatic.
4. It's pancreatic enzymes that are available on prescription.
Okay, it's a brand or it's a mixture of 4 types? Or?
Only pancreatic elastase. It's only pancreatin. Yes.
And so someone with this sort of deficiency in my patient's picture, how long will she be on the Creon for?
You will need to monitor. It's something that you would need to monitor. So have a look at her pancreatic elastase later down the line.
Right.
You might want to refer her onto an endocrinologist to work out whether there's any other underlying issues. Does she have any, has she lost weight suddenly?
Yeah, it was gradual over the whole diagnosis of insomnia and IBS-D.
Yes.
But I would say that we
don't rule out any pancreatitis. So she might need referral to a specialist for that reason. So you might want to rule that out. Yes.
Right. Okay. Just very quickly back to the fecal zonulin. You mentioned that zonulin is almost a hallmark for
it's a hallmark for leaky gut. It's also a hallmark for zonulin. Is when zonulin is elevated, there's generally Dr. Fasano is the doctor is fairly well known, well published in discovery of zonulin. He's found that elevations in zonulin is associated with leaky gut, and zonulin also is also found that it's associated with gluten tolerance. So if you find that zonulin is elevated, it's a good idea to ensure that your patient is abstaining from gluten during this treatment process.
Yeah. Okay. And on the good bacteria bit, the Akkermansia was low. You would have probiotic strains that replace that directly, or?
There is no direct probiotic available in Australia that increases Akkermansia. It's a combination of diversity, right? So you need to actually do larger immune supports. You might need to encourage your patient to increase foods that are rich in those mucins, such as the Japanese, the sticky bean thing they do.
Natto,
Natto beans. There's you could use some of the kinases, natto kinases as well, peptide kinases, streptokinases, those sorts of strategies. But that's in level 3 and level 4 of your treatment.
Right. After we've settled the antibiotics. Yeah?
Yes.
Right. Just so I did mention in the notes that I sent yesterday that the patient was on something called Spore Biotics, like subtilis coagulans, because when we do our research, we found that prebiotics sometimes is digested in the gut through the acids, and so
Spore Biotics versus commercial probiotics.
Okay.
The differentiation is only about where it's derived from.
Okay.
So Spore Biotics have been found to be derived from a source. Some of them are derived from the ground, and they've discovered that those are less reactive to some people. So I think I can't tell you whether one is better than another for a patient. The ideal way to approach it is to actually look at, or probably pulse her with a Spore Biotic, with a anti-inflammatory probiotic, with a regular multi-strain probiotic, so that you can get that diversity happening and get her to respond to you as to whether one is better than the other. It's like your protein powders. If one is actually derived from a fermented source as opposed to a whey protein or a pea protein or a fermented protein source. So they find that the fermented protein sources provide a more bioavailable form of the protein, and the same could be said for your probiotics from a spore-derived source.
Right. So do you have examples of these fermented protein powders?
Oh yeah, there's plenty of them available here in Australia, and they are, you can definitely get them online, I'm sure, but they basically a combination of proteins that is in actual fact derived from a fermented source. So it could be a fermented pea, fermented brown rice protein. So that's what you would look into.
And that's completely different from nattokinase, streptokinase.
No, your kinases are different.
Mm-hmm.
They are actually, breaking down your bacterial colonies. So your kinases are in actual fact used in conjunction with antibiotics, because your antibiotics live in colonies, right?
Right, okay.
This beautiful little protective wall around themselves so that they can multiply. So your streptokinase, your natokinases are in actual fact powerful invaders of those walls of the colonies, right?
Okay, understand.
So, yeah.
So, okay. Alkalizing strategies, what are those? Haven't really heard of those before.
So there is one formulation that I use constantly, and that is a magnesium citrate formulation. I can send you some information about it. There's some really great alkalizing strategies. One of the major things is most acidic driver is stress. So if she's really stressed, that's truly acids. And what do acids do? They corrode the body, right? You pour acid on anything, it'll corrode, right? So exactly what's happening in her gut, she's terribly inflamed. So therefore, you might want to look into her driving down that calprotectin through alkalinization. Easy way to alkalinize is use vegetable juices daily. Using sodium bicarb in water. But you've got to be careful you don't alkalinize too much. So you monitor your pH accordingly. Using really good electrolytes can alkalinize. There's a formulation which is a MagSit formulation, specially devised to actually alkalinize, and it's really powerful. If you like, I can send you some information on it.
Sure. And just mention that prior to this test, the patient was on the Spore Biotics for about 2 months. So do you think it did her any good at all? Or
if you have a microbial infestation, putting a probiotic in there is really just throwing good money after bad.
Okay.
If you've got an infection, get rid of the infection first. So you've got to go through the 4R protocol in order to ensure that the probiotics are actually being utilized effectively.
In the course of a diagnosis over the last 1 or 2 years, in fact, just as recent as I think last December, she was actually on a course of Avalox, which is the ciprofloxacin group, because she did have some greenish stools with mucus. But then once the 7-day course is finished, then we just stopped at that, and then she would go back to her probiotics. We didn't really do the herbal antibacterials.
Because she has such severe inflammation, because she has green stools, because she has diarrhea, all of those are reasons why I would encourage you to do the antibiotic therapy followed by a herbal antibacterial therapy. So that you're not getting reinfestation, right? There's no guarantee that all of it is gone because she hasn't built up her immune reserve yet. So you need to go through those 4-step processes.
Right. Okay. And so your take on the university hospital asking her to join the rifaximin trial, she should be ready when she has gotten rid of all her bugs, or can she do it concurrently?
I don't know the justification for rifaximin if she is SIBO negative.
Okay.
So perhaps you need to inquire or just get justification of the rifaximin.
Right.
And rifaximin might be beneficial for her, and that might be all that she might need. So I can't answer your question.
Okay. Maybe we can run a SIBO test, right? And just to confirm.
Well, the ideal thing is to get the methane and hydrogen breath test done, not just the hydrogen, because hydrogen is really identifying what is happening in the proximal part of the small intestine, whereas methane, methanogenic bacteria, they actually chomp on the food sources of the hydrogen bacteria, and that's usually found in the distal part of the small intestine. So therefore, and that actually transcends into the large colon, and she's got a lot of bugs in the large colon, so it's likely that she has small intestinal bacterial overgrowth just based on the fact that she's got a large amount of microbial infestations in the large colon.
Yeah,
But
I'm
at the
sure
same
it's tracked up.
Exactly.
Right. But your patients, Dr. Vanita, who are diagnosed with SIBO, are they very symptomatic with a bloated gut and a huge tummy? Or...
Exactly. So typically, I would encourage people to look into a SIBO test if they have the typical SIBO symptoms, where they bloated, they changes of constipation or diarrhea.
Okay.
They have upper GI symptoms. So that is usually associated with indigestion, GORD, Helicobacter pylori, those sorts of issues. And the key here is they unresponsive to fiber. Fiber tends to upset them. Those are the criteria under which I would consider a SIBO test.
Okay. So, Dr. Edward, we have a SIBO test in WellLab?
Yes, we do indeed.
It's a breath test, is it?
Exactly, it's a breath test.
Yes.
Yeah,
okay.
with multiple.
Both hydrogen and methane breath test, and you do need both of those parameters, because I don't want to see what's going on in my upper GI. I want to see what's going on my upper part and the distal part of my small intestine if I'm doing a SIBO test. And I don't only want to see what's happening in the first 2 hours. I want to actually extend it to 3 hours. So NutriPath actually offers the 3-hour test.
Okay. Yeah.
And we can look at the ratio as well, right, of these two gases.
That's correct.
Right, I think that's about it for me.
Right. The doctors have any reflections or questions? We have a number of other practitioners. So how long, Vanita, would you suggest we redo this microbiome test?
So the microbiome test, the objective here is we identified what was going wrong with this patient based on their test results. We then need to go through the treatment. The treatment, firstly, the first lot of treatment will usually, the stage 1, which is remove, will take about a month. Stage 2, stage 3 will take up to 2 to 3 months. So therefore, I would recommend a retest in 3 months.
Right. Yeah. And we also have the CDSA 4+, right? Would it be additionally valuable to, because there are some things there which are not here, or that is not necessary, do you think?
So the CDSA 4+ is a different technology for the microbiota. It's using a multi-TOF technology versus the Complete Microbiome Map, which actually uses a PCR technology. So that's the first major difference. Then there's the CDSA 4+ also identifies other parameters like metabolic markers, absorption markers, those sorts of markers that you might not find in detail in the Complete Microbiome Map. Yes. Right.
So it will give us a more complete picture to both together, although there are some overlaps due to of the analytes.
That is correct. Yes.
So it's sort of reconfirmation of some, but additional information also.
That's correct. Yes.
Fantastic. Right. Yeah. So
Dr. Grace and Dr. Elika, any questions?
Yeah.
All right. So Marilyn, are you comfortable with where we're at?
Yeah. Probably just liaise with you in the email about some of this, the alkalizing therapies, and maybe the anti-inflammatory probiotics. Yeah.
Sure.
Yeah.
Okay,
we're good.
Thank you.
Great. Thank you all.
Thank you so much. Bye.
All right. Bye-bye.
Bye.
Thanks a lot. See you then.